Today's lecture will be about the hand ultrasound. We are going to talk also about the technique and the common pathologies. Regarding the flexor tendons, there is the flexor digitorum superficialis tendon and the flexor digitorum profundus tendon. The flexor digitorum profundus inserts into the base of the distal phalanx, while the flexor digitorum superficialis splits into two bands, inserting into the base of the middle phalanx. That both tendons are attached into the bone by the pulleys. There are five pulleys at the flexor region. The A1 pulley, which is seen at the head, near the head, or the side of the head of the metacarpal bone, followed by the A2 pulley at the proximal phalanx. Then at the region of the head of the proximal phalanx is the A3 pulley, followed by A4 pulley at the middle phalanx and A5 pulley at the head of the middle phalanx. In ultrasound LS view, both the flexor digitorum superficialis and profundus tendons may appear of similar appearance. The upper tendons are the flexor digitorum superficialis, and the lower tendons are those of the flexor digitorum profundus. A hypoechoic structure may be seen here, which represents the pulley in LS, which is better visualized in TS view. This is a TS view for the flexor tendons. The one below is the flexor digitorum profundus, and this is the splitted fibers of the flexor digitorum superficialis before its insertion. This is an example of the pulleys appearance in TS view. I prefer this view where we see both tendons of two adjacent digits in the same TS view. This will help us to distinguish any abnormality in any of them. If we suddenly found loss of fibers in here or buckling of fibers in one side, it will be easy for us to pick up the site of the pathology. As for the extensor tendons, it's formed of a central slip that inserts into the base of the middle phalanx and two lateral bands inserting into the base of the distal phalanx. These tendons are very thin tendons, so we preferably examine them by putting a lot of gel and just apply the probe on the surface of the gel, not to do much compression, in order to give us a view where we can see the skin, the subcutaneous tissue, and the tendons. A very high frequency probe may help us see these thin tendons. Here we notice that this is the site of the central slip, and this is the insertion of the two lateral bands, or one of the lateral bands at the distal phalanx base. This is a TS view for the central slip and the two lateral bands. We also examined the ulnar collateral ligament, which is very famous for the lesion known as gamekeeper's thumb in case of its injury. Also, in cases of injury of the ulnar collateral ligament, it may be displaced beneath the adductor aponeurosis, which is known as a Stenner's lesion, and this will be discussed in the pathology later. Another structure examined in the extensor surface is the sagittal band, seen at the region of the metacarpal heads. These bands attaches the tendon to the bone. In cases of injury of this any side of this bands, this will lead to subluxation of the tendon. So examination is done while closing the fist in this position and while opening our hands in normal state. This dynamic maneuver will help us see whether there is subluxation of the tendon at one side or another. Usually we see the subluxation while the patient is closing in his fists, like in this picture. This is the normal appearance of the tendon by ultrasound, and these are the two sagittal bands. This is the video for demonstration of the flexor tendons. We can ask the patient to do flexion or extension of the distal interphalangeal joint to see the movement of the tendon for assessment of any trigger finger. This is the metacarpophalangeal joint. This is the proximal interphalangeal joint, and this echogenic structure is the volar plate. And this is distal interphalangeal joint with insertion of the flexor digitorum profundus tendon. The superficialis tendon inserts at this site. These hypoechoic small areas are the site of the pulleys, which is better seen in TS view. This is the volar plate again, and this is a dynamic examination showing the free mobility of the tendon. And this is the site of another pulley. Then we move the probe TS. And this is the pulley in TS view. The flexor digitorum tendons. This is the site of the split of the two of the superficialis tendon, and this is the flexor digitorum profundus. Moving on to the examination of the extensor group. The tendons are too thin. They apply gel on the skin and not to apply pressure. Then we move with the tendon in order to see its insertion. Any abnormality in this thin structure will be seen as increased thickness, thus denoting a presence of a tear or a partial thickness or full thickness tear. This is the examination of the sagittal bands. Again, we put gel and not to apply the probe with compression on the skin. This is the gel, and this is the extensor tendon and the two sagittal bands. Then we will move to the pathologies. This is an example of tender tear of the flexor digitorum profundus tendon, where the tendon is retracted with the avulsed bony fragment. We notice here that there is a fluid at the site of the avulsed fragment, and this is the site of the fragment avulsed. This is here the thickened flexor digitorum tendon with the avulsed bony fragment. Here is another example of the torn fibers of the extensor tendon with normal thickness and increased thickness at the site of the retracted fibers. Here, this is the normal appearance of the fibers. As we notice here that there is increased thickness of the torn retracted fibers. Another example also seen here with the two edges of the torn fibers with gap filled with fluid. It's very important to describe the exact site of the tear and measure the distance of the gap. This is an example of the pulley rupture. As we said before, that the pulleys attaches the tendons close to the bony surface. In cases of pulley rupture, the tendons are just seen moving away from the bone. This is an acute setting where we see here that there is a site of the pulley rupture with fluid, and fluid also seen under the tendon that is seen moving slightly away from its normal site. In this case, this is an like a chronic setting because we cannot see any fluid, but just we notice that the tendon is moving much far away from the bone, denoting a chronic pulley injury. Another very common pathology seen is that of the rheumatoid arthritis in the hand, where we see the synovial proliferation, the increased vascularity, the fluid around the tendon denoting tenosynovitis, and the bony erosions. Another pathology is the giant cell tumor of the tendon sheath, where we see a soft tissue mass surrounding the tendon. This soft tissue mass may have little increased vascularity, but it is very important to do a dynamic study, as usually in cases of giant cell tumor, the tendon moves freely through this mass with no evidence of entrapment. And this goes with the diagnosis of giant cell tumor of the tendon sheath. Another common pathology seen is the foreign bodies in the hand. Well, here we see that there's multiple foreign bodies, and this is one foreign body with reactive granulation tissue around it. Sometimes we may see abscess formation around the foreign bodies. This is an example of a trigger finger, where we notice here that there is a mild decreased thickness of the pulley. This is the thickness of the tendon, which is seen narrowed as it passes under the pulley. And we can do a dynamic study by also doing a flexion and extension of the distal interphalangeal joint, where we see the tendon is moving difficultly. Here is another example with the pulley seen much more thickened, while the tendon is more or less moving better than the previous case. Another pathology seen at this region is the GP tron contracture. The patient usually complains of flexed fingers, usually at the fourth and fifth digits. When we do the examination by ultrasound, we find this hypoechoic lesion near this. Classically, it is at the site of the opposing the site of the fourth and fifth metacarpal heads in the subcutaneous tissue. This represents fibrous tissue leading to the flexion deformity seen at the 2 digits. We may also see a volar plate injury. This is the appearance of a normal echogenic volar plate. And this is an example of an avulsed volar plate with the fluid seen beneath it and around it. This is the example of the ulnar collateral ligament injury. In plain X-ray, we usually see the avulsed fragment of the proximal phalanx of the thumb. In ultrasound here, we see the thickened injured tendon with the avulsed bony fragment. Here is another example where we see that the tear is seen at the middle aspect of the ligament with the 2 torn edges. A comparative study may be helpful to distinguish the difference between the 2 sides. Here we see the normal appearance of the ulnar collateral ligament at the asymptomatic side, and this is the appearance of the torn ligament at the symptomatic site. We mentioned before that in cases of the ulnar collateral ligament injury, if the torn fibers are retracted beneath the adductor aponeurosis, this is known as a Stenner lesion, and this injury is corrected surgically. So it's very important to assess whether there is any abnormal fibers moving away from the site of the injury. The extensor carpi ulnaris is a tendon that is seen at the medial aspect of the ulna at wrist joint. This tendon is very commonly affected by tenosynovitis. Also, in cases of injury of the overlying retinaculum, it may subluxate, and this subluxation occurs in supination position, and the tendon returns in normal position in pronation state. It's also very important to examine the vascular structures of the hand. As one of the cases I met before is that was complaining of hypovolumic thinner muscle. On examination of the muscle, there's no much abnormality seen within the muscle fibers. However, the radial artery at the wrist joint was normal. While examining the artery in the anatomical snuff box, I found that it was totally thrombosed, and this was the cause of the patient's complaint. Here is an example of the normal sagittal band, and this is the site of injured band leading to subluxation of the tendon, and this subluxation may be as much as it moves to one side of the bone. Thank you very much.